Hello, everyone. My name is Sebastian Van Gils. I'm a technical officer of health systems governance with WHO's Eastern Mediterranean Regional Office in Egypt. So on behalf of WHO and our partners, the Health Systems Governance Collaborative and the Middle East and North Africa Policy Forum, I'm excited to welcome you to today's webinar. With COVID-19 cases surging in regions around the world and large-scale rollouts of vaccines coming soon, unprecedented levels of collaboration and collective action will continue to be required. So perhaps now is as relevant as ever to be discussing governance and common goods for health. So we will begin. This is a quick overview. We'll begin the session with presentations from our speakers, Dr. Agnes Soucat and Dr. Hala Taleb, and this will be followed by interventions by our moderator, panelists, and discussant. We'll then have the moderated panel where the audience questions will be discussed. And lastly, there will just be a few closing remarks and a quick word from our, about our next webinar. So without further ado, I would like to introduce our session moderator, Dr. Maryam Bigdeli. She has nearly 20 years experience working with WHO in a myriad of areas, including health financing and governance. And she's currently the WHO representative to Morocco. And we're very honored to have her here to moderate today. So the floor is yours, Dr. Bigdeli.
Thank you very much, Sebastian, for this introduction. I will not take a long time. I will just very warmly welcome all our speakers and panelists today. And I will let them speak one by one for a very interesting and I hope fruitful discussion and engagement. We are really counting on the audience on the floor to be able to bounce back some questions and comments about this very interesting topic for us. So without any delay, I will introduce our first speaker. Dr. Agnes Soucat is going to talk to us about governance for common goods for health in the times of COVID-19. So Dr. Soucat, many of you probably know her already, is the Director, Department of Health System Governance and Financing in WHO at headquarters in Geneva. Before joining WHO, she was the global lead in health, nutrition, and population at the World Bank. She has many realizations, and among others, she's part of the Lancet Commission on Investing in Health. But that's not the only Lancet Commission or publication that Agnes has taken part of. She has over 25 years of experience in health and poverty reduction, covering Africa, Asia, and Europe. So Agnes, you have the floor for your presentation for 15 minutes. Thank you very much.
Thank you very much, Maryam, and good morning or good afternoon to everybody who is joining us today. So these are extraordinary times, and the pandemic that the disease X, tsunami, that we were talking about in semi-confidential publications for years is now here. And now is time for governance for common goods for health. And this is what this session is going to discuss, is really how do we go about collective action in health when we have to face intractable problems, when we have to face problems that affect all of us. The COVID-19 pandemic has affected everyone on the planet. This is the true globalization. And as globalization delivered on economic growth and on poverty reduction, we've seen a rapid decline in poverty over the past decades. We've seen most countries getting richer. We've seen at the same time that the market failures have not been addressed. While markets were globalized, governance has not been globalized at the same space. So what are common goods for health? How do we define that? They are for health, so they are goods which generate health benefits, but their production or maintenance is constrained by the physical impossibility in the current stage of technology to charge a price or a fine to some or all of its consumers. And this is why the market cannot handle them. If we rely on decentralized decision through the market, what we get is under provisions because producers cannot charge the production cost, and overconsumption of the good because consumption do not integrate the cost of their utilization in their own economic decisions. Because of that, the cost of the response or the cost of the repair is often very much bigger than the cost of prevention or maintenance. That's economic theory. And in this particular case, economic theory is incredibly validated by the crisis. While we saw the market producing better income, producing reductions in poverty, we've seen that there has been very large blind spots in what this market has delivered when the common goods have not been funded through collective action, particularly through government. So common goods are by definition not delivered by the market. It is the definition, which means that they are at the center of collective action, which means that in the 21st century, they are at the center of what is the most institutionalized expression of collective action, which is the modern government. So common goods for health is what governments need to take as the very first priority, and what has been recently defined by the UHC 2030 partnership and the UN Secretary General as the step 0 of universal health coverage. Before we start discussing the delivery and distribution of private services, the first role of the government is to fund, to make sure that the common goods, the market failures, are addressed. What are the examples of these common goods? For most of us who have some familiarity with economic theory, the ultimate common goods that have absolutely no role, that are completely pure are the public goods like clean air or climate stability or biodiversity. And then there are common goods that have some market involvement, but they also have major market failures. That's safe water, the absence of antimicrobial resistance, herd immunity against a disease. There are even areas that are very much at the heart of governance, which is the trust in health authorities. So what are the consequences of that? The consequences is that one cannot charge a price. The production of common goods for health cannot rely on decentralized forces. They cannot rely on market forces. Therefore, they are a challenge for collective action. Some coordinated governance and collective financing are just needed to maintain or increase the stock of the common goods for health. Collective financing in most circumstances means public resources, means government intervention is required. And back in, at the end of 2019, we actually, a group of economists and public health specialists produced a special issue of Health Systems and Reform, in which a series of articles looks at this issue of financing common goods for health. What are the boundaries of common good for health? Why is it that the market cannot deliver them? Why is it that we either get under provision or over provision, but mostly under provision because of what is often called the free rider mechanism? in which people don't realize that those common goods are important because they don't have to pay for them. They cannot buy them. And they belong to everybody. And they are not shareable. And you cannot exclude anybody from them. So there is generally a lack of salience, a lack of understanding of the importance of these common goods until something like COVID happens. And what we have seen in the early days of the response to the COVID-19 pandemic is a rush of most countries to increase the funding of those common goods: surveillance, public health institutions, coordination, information of the public, data analysis, regulation, public health programs. Suddenly we saw massive amounts of money directed there, but in many ways at a very late stage, because by then the extreme health event had happened. And it was no longer a matter of preparedness, was no longer a matter of avoiding the extreme event, but it involved a massive response which involved the entire health sector and overwhelmed the entire health sector. Beyond that, it actually triggered massive loss in human health, whether in terms of morbidity or mortality, massive number of deaths, accompanied by a major economic crisis. And in this special issue, we actually calculated the cost of investing in those common goods for health, which we estimate overall with revised analysis of the WHO to be somewhere between 100 and 150 billion per year for a period of 5 years to really bring about, additional to what is already spent, to bring the investments into the essential public health functions, the investments into preparedness to the level that is needed to address and anticipate major health threats to people at national level, but more broadly at global level, such as the COVID-19 pandemic, such as the threats that are upon us of climate change and loss of biodiversity. Clearly, there is a need to invest much more in functions such as One Health, such as environmental health, such as surveillance, lab capacity, such as regulation and regulatory institutions, such as data systems that are providing information that can be used globally in a standardized way and are able to identify those threats. And also putting to work fiscal instruments such as taxes and subsidies. So in many ways, all the gains in global health that were achieved over the past 2 decades were due to economic growth and new technologies. In fact, when we look at the UHC index that measures the utilization of health services over the past 20 years, we find very little impact of any other intervention than actually the improvements of the income of countries and people. And this doesn't say that public spending is not important, but we have had massive health improvements that were driven by the economy. But within those improvements, somehow we missed the blind spot. And it's not that we completely didn't know. The Ebola crisis had been, in 3 Western African countries, had been a wake-up call that the gains in health and the gains in well-being and welfare that were linked to economic growth could be reversed. They could be threatened. And that there was a need to invest in preparedness and essential public health function that are those common goods for health. So the Financing Common Good for Health Technical Expert Group identified 5 areas of action to maintain or increase the stock of common goods for health: information collection, analysis and communication, policy and coordination, regulation and legislation, taxes, fines and subsidies, and population-wide services. As you can see very clearly, those functions that the market cannot deliver, those functions that are at the heart of the role of government and need to be provided as the very first priority of public financing, the step 0 of UHC. So the next step for this agenda, the next step is today. Because if we look at this through an economic theory lens and a financing theory lens, it is actually quite straightforward. A lot of what I just said, you know already. And financiers, ministers of finance, treasuries, economists, they know what public goods are. They know what common goods are. They know that this is what needs to be funded first. So it's not really a financing issue. It's not really an economic issue or an economic theory issue. What it is, it's a governance issue. Why? Because what we see is the failure of collective action. The main reason why there is under provision of these common goods for health is the lack of collective demand of people as a citizens' body for the public purpose to be allocated to these common goods. Why? Because of lack of understanding, because of lack of knowledge, because of lack of consensus and agreement around different groups in a society, lack of cohesion in the society, maybe different groups wanting different things. And also because of vested interest. Common goods are not really aligned with market forces, since this is actually their very definition. This is where market fails. And they are often not aligned with market interest and with the interest of particular groups, financial interest, power interest, that are not aligned with the provision of these common goods. But as a global community, we're making a lot of progress on developing collective actions through common agendas. Some of these arrangements are at global level. The 2015 Paris Agreement, for example, is an agreement, is a common good, a collective agreement at global level. We know there are some also at national level, but some may be also at community level. And the work of the Nobel Prize Elinor Ostrom actually showed that. So when we talk about common goods, what is at the heart of it is the collective action. And the fundamental difficulty we have when we work on governance is how to organize ourselves and how to develop the institutions that are going to support the commons. How are we going to address the cohesion failure in the society? Because, for example, of multiple identities in a society who are not working together in actually building a consensus about where the common purse needs to go, how the funds of the common purse are allocated, what should be funded by the common purse. And yes, they are global common goods, such as issues around climate change, but they are national ones and they can be community ones at decentralized level. When we look at common goods for health through the lens of governance, we can use the governance triangle, the framework for analyzing governance, in which we have three main actors: the state, the policymakers. The state can be a national state, it can be also decentralized states. But the state is the agent of the people in charge of preventing and fixing the market failures. So you have people who are the principals and they authorize and they give the mandate to the state. So the people in blue give the mandate to the state to take care of the commons. But among the people, the fundamental issue is for those people to agree on the mandate that they give to the state. But there is heterogeneity of people in the principle. Societies might be very fragmented according to different lines. They can be fragmented according to economic lines, with poor and rich and middle class. They can be fragmented according to geographical locations and circumstances that are very different. They can be fragmented according to social structures, such as caste or social positions. They can be fragmented according to religion or or ethnicity. The problem of collective action is also a problem of building a common identity. And in many ways, the under-provision of common goods for health is linked to a root problem as to whether the state is an agent for the whole population. Is the state representing the entire population, or is it captured by either special groups or special interests? And how can we work at institutions that are going to foster a collective action that is inclusive and represents everybody? Because guess what? When it comes to common goods, it is everybody. It's not a choice. The clean air or the prevention of a pandemic, there is no way that just a special group can capture it. It has to be for everybody. So by definition, common goods are, again, the step zero of equity. So the heterogeneity of institutions and societies is at the root of the governance problem of common goods. There are different social contracts, there are different political undercurrents, there is a different institutional history, there is a different types of nation formation. We know that not all countries are based on one nation. Many countries have multiple nations. Many nations are cutting across borders of modern states. All of this is an obstacle to common goods. Even nation states, in a way, are an obstacle to global common goods. And that's why in the 20th century, nation states agreed to plant the seeds of a global government, first through the Society of Nations, then to the UN. So today, we have, the closest we have to a global government is the United Nations. But then the identity issues become even more pronounced, because then you need to build the agreement of the billions of people who live on the planet today.
Agnes,
And
can I ask you to please conclude?
I was about to conclude. So working on the governance of common goods is really working at this question of people heterogeneity, people as principal and how they convey a message to policymakers, and how policymakers, together with people, discipline and monitor the market, the providers, so the red one on the right, that deliver the services and respond to people's demand. Thank you very much.
Thank you very much, Agnes. I think that one of the essential questions that we need to discuss is how can we increase the demand for global goods for health, and how can we go towards social contracts that allow this demand to be increased and create a cohesion that lead us to increase the demand for global good for health. You have also very importantly listed, for example, when you refer to the COVID-19 example, you have listed a certain amount of functions such as surveillance, regulation, population information that were all of a sudden massively funded due to COVID-19. Actually, you have listed essential public health functions. So this is a transition for me to give the floor to Dr. Hala Abou Taleb on the second presentation of today. More specifically, Dr. Hala Abou Taleb will talk to us about these essential public health functions. So Dr. Hala Abou Taleb is the Regional Advisor for Health System Governance with the WHO Regional Office for the Eastern Mediterranean in Cairo, in Egypt. She has worked earlier in her career with other United Nations agencies and has a lifelong interest in public health issues, including health system governance, accountability, legislation, human rights and equity, as well as evidence-based policies and planning in different settings, including in fragile contexts.
Thank you very much, Maryam. Before I start, I would like to thank everybody who and all panelists who accepted to be part of this webinar. My presentation, as Maryam said, was try to complement what Agnes mentioned, just articulated with us, and to throw some light on the regional challenges and way forward. So just articulating on what Agnes just mentioned, she just shared with us the common goods for health from the health financing and economic perspective. I will not repeat them, but they are, when we're which are at the regional level, what we call essential public health functions. Okay, essential public health functions have been defined as the indispensable set of actions under the primary responsibility of the state that are fundamental for achieving the global public health, which is to improve, promote, protect, and restore the health of the population. And I would like to focus here on the last part of this phrase, which is through collective action. So the key points here is primary responsibility of the state and collective action. In 2013, WHO launched an initiative to assess essential public health functions and developed it, and you can find the list of the essential public health functions illustrated on the right side. Each of those functions, actually, they have a multitude of sub-functions and details and how to assess them and how to monitor them. But unfortunately, we're not there yet how to measure them. Going back to the role of the state when it comes to common goods for health, or essential, what you call essential public health functions. It's very important to focus on what is the role of the government to promote and protect essential public health functions. This is not a luxury, and this is not something that should be left to the market to regulate itself or coordinate itself. So the government needs to step in and claim their role through, of course, based on the delegated social contract with the people, to oversee, lead, and coordinate those functions, and not leaving them to the market interest and public and to protect public health. At the same time, to make sure that they engage in the collective action and engage with all partners, whether private sector, civil society, different representatives of the population, of the people, academia, and alike, in the development of policies and regulations, to make sure that they can promote and protect the essential public health functions and deliver public health services. So, what's the added value of collective action? The collective action is very important in the health system transformation in countries to achieve universal health coverage and health security. And this needs to be done through setting the long-term shared vision. It requires governance mechanisms, health system governance mechanisms, and institution setups to support this process and ensure which should be based on data, evidence that can guide the policy dialogue across the different actors of the society and governmental sectors to identify priority health decisions that needs to be undertaken and needs to be addressed based on the capacities, the resources that are there, the institutional setups which are there. What are the Eastern Mediterranean health system governance challenges? I'm not going to read this a long list, but I'm just trying to touch very quickly on what's the situation here. First, the health systems in the Ammar region has been facing throughout the decades multiple shocks, whether from natural disasters, whether conflict, emergencies, whether outbreaks, and alike. The institutional setup and arrangement are not fit for purpose, and they are fragmented and sometimes inefficient. And many times you find that the health systems are actually depending on funding coming from international partners and donors. And when we visit the essential public health functions and review them, you'll find that they are not well defined and well assigned to the different health system actors, as well as the linkages, as Agnes was beautifully articulated, that the different dynamics and linkage and power relations between the different stakeholders are not well regulated, are not clear, and sometimes there are conflict of interest or even gaps in the architecture of the health systems that will impede achieving the common goal or the vision. And of course, there's a lot of inequity when it comes to COVID-19 in delivering COVID and non-COVID essential health services, which we've seen lately that there were all the non-COVID essential health services were interrupted because all the forces were, or the government forces were directed all of a sudden to meet the challenges and prevent and promote actions to mitigate the risk of COVID pandemic. When it comes to policies and regulations, they are not based on priorities, or they don't take into account the existing capacities and institutional setup, and they are not aligned with what the required transformation strategies and the institutional setup required for achieving universal health coverage and health security. And unfortunately, there's weak accountability measures and mechanisms inherited in different sectors, and to help the government to be able to monitor performance and social accountability and shared accountability across actors. When it comes to the areas of emergencies and what are the governance priority areas in emergencies, we find that the core areas are multi-sector health security coordination and accountability indicators were very much a core area that needs to be strengthened. This is an area that is weak, and this is what we learned from COVID-19. Similarly, operational emergency preparedness and response plans were not aligned with and not efficient enough to meet and face the pandemic, and there were not efficient monitoring and transparent reporting mechanism in place. Going back to the most important thing in my view is that social protection policies were not taking into account any or prepared for any shocks, health system shocks. That's why the first thing the governments try to do is to quickly amend and make sure that they can protect this, pass regulations and enforce social protection policies to protect the vulnerable groups and marginalized population during the pandemic, which were severely impacted by the economic shock that was imposed by the pandemic. A lot of actors, stakeholders, like the parliamentarian, private sectors, civil society, academia, were not engaged actually in the health decision making, and whether in emergencies or even outside the emergency context. Of course, the COVID-19 and emergencies brought innovation, as you rightly mentioned, new health technologies that needs to be regulated, not to be left out to the market. as well as the other regulatory measures. So I'm trying here to share with you some of the regional observations. Why do these governance challenges exist, and why countries are not investing in essential public health functions? Health system governance is already complex and is further compounded by politics, which are influenced by different expressions of identity and post-colonial heritage. In addition, economic determinants put additional pressure on governments to continue in their comfort zones and focus on quick fixes instead of investing in essential public health functions and systems strengthening. This led to a very vicious circle of inefficient and unsustainable short-term investment in health, rather than investment in systems transformation for more efficient governance arrangements and investment in essential public health functions. Why investment is not taking place in the essential public health functions? Governments, as I just mentioned, governments, because of the different determinants that were shared by Agnes, and we'll see that governments, they want to go for, they want they're more interested in short-term political gains. There's a lot of pressure and cultural, if I may say, population. The population in Ammar, they're more relying and used to not winning in any states, where they are depending on cash flows, subsidies, and on the medication, receiving medication, instead of systems reforms to make sure that to promote and protect public health. This put a lot of pressure on governments who wanted to, they didn't see any point to, or pressure or collective action to push them in the other direction, which is systems reform. So lack of participation and community engagement in decision making led to top-down approach, and which is politically and economically driven. The economic conditions and political instability and humanitarian context in Ammar also prevented sustainable and longer-term systems reforms. What happened to COVID-19 in Ammar? What happened is that early in the pandemic, head of states led the response in a top-down authoritative process, which was initially successful in curbing the pandemic, but not for long. Weak engagement with the community in health decision-making and implementation, including private sector, civil society, legislators, public health institutes, academia, had a negative impact and proved to be a lost opportunity to build bridges of communication and trust between the government and the population. This was demonstrated by incompliance with public health preventive and promotive measures, and obviously by increasing in the number of cases and escalating the negative economic impact of the pandemic. It also demonstrated that there was weak governance arrangement, which also led to market failure to respond to the pandemic. It was obvious that quick fixes will not work anymore, and it is time for investing in essential public health functions or common goods for health, institutional arrangements and capacities, and to promote the role of government. This is crucial to avoid further political and economic loss, and more importantly, promote and protect people's quality of life and the right to healthcare. Lastly, it also demonstrated that collective action in decision-making and monitoring implementation is a must. Governments need to promote and create an enabling environment through strengthened institutional arrangements and regulations in support of community engagement and shared accountability at both national and subnational levels. What did we do in Ammar is that we developed different tools based on the diagnostic tools that Agnes just alluded to help in undergoing governance mapping and identifying bottlenecks and entry points for reform and transformation. This and we developed also institutional assessment tools with and we attempt to develop a M&E framework to be able to monitor their implementation. All this is based on essential public health functions. The approach in the regional in applying those tools and trying to help identify country context, because there's no blueprints in transforming health systems or reforming it. this has to be country-driven exercise, is to start by having a task force working together along with them in a participative way, how to share with them the tools. They need to identify where are the bottlenecks under good analysis and mapping themselves. They identify the bottlenecks and gaps, and then we go through a process of consultation to identify where are the entry points and priorities and where should we start, all in a collective action mode, meaning that all actors and all beneficiaries should be sitting around the table. Of course, there are issues. WHO already developed tools to help and address these challenges facing collective action, like representation issues, regulations issues to centralize the process. There are a lot of details that WHO is trying to address and support countries in this process. So we work closely with countries because, as I said, we need to they need to do it themselves. They need to know it's doable, and the reform that has to be led by the countries themselves. In summary, COVID-19 renewed emphasis on need for countries to invest in collective action and in promoting and protecting common goods for health. Using essential public health functions and common goods for health, which are our definition of common goods for health, as a starting point, countries must continually identify and address institutional gaps and capacities and bottlenecks to better protect health as a common good and improve health systems performance. Approach to health system governance continues to evolve over time. It's not one step. It is a phased approach. It's a journey. We need to strengthen the role of the government in promoting and protecting the common goods for health, improve institutional arrangements and capacities to be able to do that and implement it, identify new entry points, bottlenecks for change, and areas of focus, and monitor set of accountability indicators, and maintain relevance and sustainability of health systems transformation and collective action for shared accountability. And thank you. I'll stop there. Thank you, Maryam.
Thank you very much, Dr. Abu Taleb, Hala, for this interesting presentation and how you have very skillfully linked the common goods for health with the essential public health functions that we in the public health arena might be more familiar with, why we have we are embracing this concept of common goods for health embedded in the economic theory. I note that you emphasize community engagement on one side and the lack of community engagement and how this might have been a bottleneck for health system reform and governance improvements, and also demanding essential public health functions or the common goods for health. And at the same time, you mentioned strengthening the role of government. So it's interesting to see how this is actually the both sides of the same coin in governance arrangements. I'm now going to give the floor to our esteemed panelists. I would say that for them, they will have each an intervention, a presentation of about 5 to 10 minutes. But what we'd like them to discuss, more generally speaking, in broad terms, is what are the challenges to health system governance, to delivering these common goods for health? What are the political challenges, the economic challenges, and other types of challenges? Because particularly, I'd like to hear from Dr. Siddiqi about some of the contribution of evidence to policy and the academia and the think tank arena to this work. Why countries do not invest in common goods for health and essential public health functions? How can we foster that? What are the lessons that we can learn from the COVID-19 pandemic to be able to promote common goods for health and essential public health functions? And how can WHO work with member states and with all stakeholders in countries, civil society, academia communities, so that we can ensure the delivery of these common goods for health? So instead of Dr. Walid Ammar, that I was going to introduce first, I would like to ask Dr. Sameen Siddiqi to intervene. He is the professor and chair, Department of Community Health Services at Aga Khan University, Previously, he worked for WHO for 16 years as he served as the Director of Health System Development in the Eastern Mediterranean Regional Office, as well as the WHO representative to Lebanon and Iran. He has worked with the Ministry of Health in Pakistan for the World Bank and over 2 decades in health system development. He has specialist interest in health system governance, quality and safety of care, private health sector, and the public-private partnerships. Dr. Sameen, the floor is yours.
Well, thank you very much. And it's a pleasure to connect with colleagues and to listen to the 2 presentations we had. Thank you very much, Agnes. I mean, you always, make presentations which makes us think, and you come up with all these new perspectives. And Hala, thank you very much for your presentation as well. So clearly, this is an area where, and let me start first with what I have heard over the last 40 minutes. And Agnes, of course, you made a very powerful presentation and a very strong case. And I thought your case had 2 perspectives. You made a very strong economic case for what you're now calling the common goods for health. And there's no question the economic theory is very strong and I think strong. But then you turned and you said that the problems and challenges of these common goods are much more in the governance domain, and we need to address it from a governance perspective. And that's where I think you brought in that analytical framework of both of the state, the provider, and the people, and so on and so forth, which I think is the way to go. So from a conceptual perspective, I think that is, nobody can disagree with that part of the presentation. I think what we will like to discuss is how do we take those strong, powerful, underpinning concepts and then take it to the level of the countries where we can start talking to our policymakers as to how does it all reflect at the national level and at the country level. Hala, you took the example of essential public health functions based on what Agnes as an example of a common good for health. And I think that is a very powerful one. I'm happy that you did that because in 2013, when I happened to be in your department, we initiated this work, and I'm very happy that that work is still continuing to happen. So very good and well done on that account. I would, from that, picking up from that, I would also like to add, if you're talking of essential public health functions, I think the whole area of international health regulations. And I think they both are very relevant, and we need to talk of one with. So maybe the EPHF is much more from a country perspective, and IHR is much more from a cross-border perspective. But they do try to address similar aspects that we have in terms of gaps, and these are for me common goods. IHR for me is surely a global public good or a global common good, and I think those are very important. Now, having said that, what does COVID bring to us? And I think we are all going through this, which has affected our professional and personal lives. We've changed the way we live and work and do things. And it has challenged us, it has exposed. But this time I have to say that COVID has exposed the vulnerabilities not only of LMICs or the poor countries, but also of the rather rich and high income countries, because we've all been seeing that public health has not been as strong as we would have liked to. We believe that it would be in most of the countries, whether they are high or low income. And that is where I think the whole area of how we actually reshape the whole work on public health. But also, I think COVID has brought in opportunities. And I don't think anybody can deny the fact that today, in at least the country where I live now, in my own country, I have never seen the Prime Minister of Pakistan and the Cabinet of Pakistan talking about public health in the last 6 months as they have done in the last 60 years. And so we must use that as an opportunity to maintain, to raise the importance of public health on the national and the global policy agenda. And I think that's a task for which we have to do some more work. So the question that I'm asking myself is, all what we have heard and discussed, how do we take it in a manner that it connects with the policymakers? And I have to tell you very honestly, in my meeting with the Minister of Health of the province of Sindh in Karachi last month, it's a province of 50 million people. And I can tell you the minister was as explicit. And she said, Dr. Siddiqi, we have to try and show things which are visible. We have to try and show things which are like structures and hospitals. And she had no problems in stating that, and that's the turnaround that we need to make, basically. So from my perspective, I would like to say that when we're talking of governance, and I would like to sort of say 2 or 3 points, and then I'd like to stop because I think we need to have a good dialogue on this. First of all, we cannot see and look at governance from a perspective of health only in a country where the overall governance has huge influence of the government. So in our region, since we are part of this discussing it in the EMR, we are anything from weak democracies to autocracy to military rule to monarchies. And they spill over the work on the governance and health, and so clearly we have to find ways how we can manage and bring, raise the level of health governance in these countries when we have these challenges in overall governance. And I would like to say that we need some normative work, since Maryam, you were saying what WHO can do and how it can do. I think some of the work on governance, which has been done in the past, but we could do a lot more. And some of the areas which are transparency, accountability, participation, government effectiveness. I would even raise the issue of ethics in governance as far as health is concerned. I think need to be brought much more and need to be in the policy discourse that it has been so far. In my experience, in our region, accountability is something that we don't even worry about. Our governments are not accountable. I mean, we have a problem of accountability in this region. We have a problem and transparency. And what is perhaps even most serious is that these are areas which are generally accepted by the people. And so somebody was saying, how do we create demand? So I think we have to raise the importance of accountability, and whether we do it through media, whether we do it through academia, whether we do it through raising it with the policymakers. But I think we need to raise those kinds of issues if we were to improve governance, and that governance will ultimately lead to the kinds of common goods that we were talking about, and in which our governments need to invest. So with that said, I think if we wanted to sum up, if we want to raise investments of our governments in surveillance, in data science, in public programs, in promotion, awareness, regulation, then I think we need to bring in much more from a governance perspective, elements of accountability, transparency, participation, effectiveness, equity, ethics, and so on and so forth. And for which I think WHO and countries and academic institutions like ours have to work together to come up with how do we actually take it to the level of the countries. So I will stop here, and I'll be very happy to listen to other colleagues as to how they see that we can translate it at the level of the countries. Thank you, Maryam, for this opportunity. Back to you.
Thank you very much, Dr. Sameen, for this insight. So I will give then the floor to Dr. Maha Rabbat for her comments on the two presentations and her insights. So Professor Dr. Maha Rabbat is the Executive Director of the Middle East and North Africa Policy Forum, appointed by our Director General, WHO Director General, as one of the 6 special envoys of COVID-19 to provide strategic advice and high-level political advocacy and engagement in different parts of the world. Dr. Rabbat is the former Minister of Health and Population for Egypt, has several high-level academic and leadership positions, and has worked as a health system and governance expert with national, regional, and international organizations. So, Dr. Maha, the floor is yours.
Well, thank you very much. It's a pleasure to be among my colleagues and all the professionals. And thank you, Dr. Hala, for this invitation to participate for a very important and timely discussion about what needs to be done now and into the future. So I would like to thank you for the presentations that you have really drawn the case for essential public health functions and essential public health function as common or public good for health. So I would like to start the discussion by quoting the need to reposition the public health functions and services as an axis of the country's response for needed transformation. So this is the cut that we have to start from, and then to move forward to see the elements that are needed in order to ensure the equity, the efficiency, sustainability, the preparedness, and the response. But this is the health system recomposition or restructures that we have to emphasize. So definitely the COVID-19 pandemic, it has underscored all the systemic nature of the global situation. with its hazardous effects on the economy, the social, the societies, on the health as well. So it has unpacked the fragmented institutional context of all the systems from the strongest, because as we can see that the pandemic has started in the more developed countries. So we could see this fragmented, or this, I won't say collapse of the systems, but the struggle and the challenges that were happening there, as well as it has as well underscored the ability of some countries to overcome those challenges. So I mean, it's a multitude of factors that has affected the response for the challenges, but it has underscored the fragmentation in the institutional context of many of the health systems in the countries as well. So it varies, of course, from country to country, but as well, the recovery as well has varied from country to country, and it has all depended on leadership and the commitment and the available resources. But the flexibility and the adaptive system was really very important to overcome many of those challenges. So we know now that there is the central role for public health and its investments, which has generally been neglected in favor of the more curative health systems and in favor of unpacking the need for the governance to guide this response. So when talking about the region, we know that we share the social cultural features, but we know as well that there are significant differences in many of the dimensions of the health systems and the health systems response, and as well of how the systems are able to respond to the health of the populations. However, we know now that if interventions are not properly administered, and if the restructuring of the health system is not geared towards a common vision for supporting of a system that includes the public health as part of its natural resources, then we know that much of unpacking or much of disruption are going to occur. So we know that the health system, an improved health system, focused on strengthening health service delivery for some time. However, at the regional level, there are inequities, and the inequities are between countries and within countries themselves. And we know as well that whatever happens, the inequities in itself would gear the function of the health systems towards the curative and towards away from the public health. So inequities as well as the inefficiencies are part of the diversion of the prioritization away from the public health. So what we're talking about now is that if we're talking equity, we're talking efficiency challenges, we need as well to address some other of the dimensions that are really affecting the response. So we know that the health functions are complex, the health systems are complex, but as well the response is as complex, and the challenges, they have to be addressed in a way that would support the needed essential public health functions, and as well as a common or as a public good for health for the coming future as well, to overcome the threats. But what with the changing needs and demands of public health, and we're always saying about the essential public health functions, and in the region, as mentioned by Dr. Hala, they're not properly defined, or if they are defined, their actions and the services are not properly maintained. So what about the changing needs and demands of the public health? And this is a challenge, is to ensure that the services adapt and respond to the changes and reflect the main current and the future needs and threats that have to be undertaken. And it is important to make sure that the essential public health functions and services aligns with the current needs and priorities, given the changing and perceived changes in the field, from the demographic, epidemiological, the unrest in the country, the people movement, and all of even the technological advancement that are available. But as well here, I would like to emphasize what has been mentioned, that there is a clear requirement to integrate and implement the IHR in the health systems as part of the essential public health functions. And they have to be implemented as integral actions that are needed to be there, and they needed to be monitored and supported. And managing this, if we're talking, requires strong policy action, We need strong policy action at different levels, at the global, regional, national levels, but as well we need to ensure that the financing instruments are available. And they are available, and they could be sustained and maintained as a public good to avoid the market failures as we have seen now. So saying this, and despite the increase in the spending on health, yet there is absence of the political incentives, as the colleagues have mentioned, to prioritize the essential basic functions due to several reasons: political, economic, social. But here I would like to, as well, to emphasize the role of the innovative technology. Every day we have innovative technologies, and this raises the aspiration of the people. It incentivizes the people's requests for more technology, and as well this puts pressure on countries to move away from what is really essential as public goods, as we're saying. And so we need to ask the question to how to institutionalize this within a curative-oriented system. And this can never be achieved without improving the way health systems and services are governed, and by identifying the factors that really influence the behavior at the global level, regional level, and as well, as was said, there are no quick fixes. We need to have an institutionalized, restructured system that is based on a common vision, a new vision that would really incorporate all the common goods for health as well into a system that is strong and that is resilient to the needs, the increasing needs and demands. And so as we're moving from the crisis management to the recovery management, this is the opportunity now to emphasize the needs of investments, and as well to be part of a renewed vision, renewed global vision, regional vision, national vision, to modify the general perspectives that any health system should target provision of health services on the curative level only. So this vision is really important, and this is the starting point, entry points for our intervention. As well as we're talking about what is needed, we need sustainable organizational structures. We need sustainable financial mechanisms. And this will never be achieved without the political endorsement and without leadership and commitment. And this is the role of the WHO, together with the organizations on the regional and national levels, how to put forward a strategy or a plan with a new vision that really develops the sustainable organizational structures. And I can never, being an academic person, I can never oversee the need for advancement of the public health research to inform the policy and the practice. And this is really important for the development of the policies and to produce the necessary changes in commitment, inclusiveness, participation, and accountability. So thank you very much, and over to you.
Thank you very much, Dr. Maha, for your intervention. I see that Dr. Walid Ammar is back with us and the power cut is now over, so I can finally give him the floor for his intervention. Professor Walid Ammar is the former Director General of the Ministry of Health in Lebanon and current Director of the Doctorate in Research in Public Health Program at St. Joseph University. Dr. Ammar has published over 100 peer-reviewed papers, as well as 2 books in health system reform in Lebanon and health beyond politics. He is officer in both the French National Order of Merit and Belgium National Order of the Crown. In June 2020, he was awarded the Golden Medal of the National Order of the Health Merit by the President of Lebanon. We are honored to have you, Dr. Ammar. The floor is yours.
Thank you very much. I really enjoyed the previous presentations, and it's the political philosophy dimension of our subject today is really important, as it was explained particularly by Agnes. However, as agreed with Dr. Hala, I will be rather practical in addressing governance issues, in particular the role of government and other partners in implementing essential public health functions, while focusing on health security, including protection, preparedness, surveillance, and response. These functions have great impact on population's health. They are subject to market failure and generate important externalities. Therefore, by nature, these functions require collective financing arrangements, as well it was well explained by Agnes, i.e. the only way for efficient and sustainable financing goes through the government. But what about implementation? In developing countries in general, the main limitation for government interventions, in addition to financial constraints, is the institutionally weak public sector that is lacking qualified human resources. Hence, the question is, how can the government rely on non-governmental resources in implementing essential public health functions, if this is possible at all? Well, the role of government vis-a-vis other partners depends on the context of the health system and vary largely from country to country. On one extreme of the continuum, the government does everything. This requires a strong public sector with sufficient number of qualified staff and efficient public institutions all over the country. On the other end, and this is where countries like Lebanon are, civil society organizations, municipalities, and even the private for-profit sector are needed to play a meaningful role in implementing essential public health functions. Practically, what are we talking about? In Lebanon, primary health care is the foundation of universal health coverage and consists of a network of health centers belonging to NGOs and the municipalities led by the Ministry of Health. Hence, the government capitalizes on non-government resources to ensure access to quality primary health care services. In return, the centers receive in-kind contributions from the government, such as essential drugs, medical supplies, material for health education and training. Whereas the ministry covers public care, hospital care, mostly by contracting private hospitals using different reimbursement models. In such a context, it is inconceivable to face the COVID-19 pandemic and relying solely on government resources for implementation. Obviously, the first response to the pandemic was entirely done by the epidemiological surveillance and response program at the ministry and the public hospitals. But the ministry could not persevere without delegation some definite tasks to non-governmental partners. And here are some examples. Private laboratories are contracted to perform PCR testing for travelers at the airport. And using the existing contractual framework, private hospitals started receiving patients, particularly when public hospitals reached full capacity. The Lebanese Red Cross, a big decentralized NGO, is actively engaged with the National Surveillance Program in contact tracing. Municipality, local NGOs, and the Order of Nurses are running together the community isolation and quarantine centers. To conclude, public-private partnerships works even in implementing essential public health functions. And whereas public financing is a must for common goods for health, non-governmental contribution is possible and I would say advisable. The requirements for a successful contribution are a history of engaged civil society organizations that are active in the health sector, well-resourced and skillful private sector capable of delivering, government that is credible to fulfill its financial obligations, and that is competent to monitor and evaluate the performance and holds the private provider accountable. And finally, and most importantly, the government leadership in a framework of collaborative governance where partners are involved in decision-making and are transparent and accountable. Thank you.
Dr. Ammar, for your presentation. Sorry that we could not take you in the order, but it was worth waiting for the power cut to be over to hear you in full. Thank you very much. I will now give the floor to our last panelist and discussant, Dr. Inaya Ezzeddine. Dr. Inaya Ezzeddine is a member of the Lebanese Parliament, chairing the Women and Child Parliamentary Committee. She is a member of the Environment, Public Health, Labor and Social Affairs Committee as well. She's a leading national and regional voice on issues including governance, reform, public service, and healthcare. She's a member of the executive board of the Regional Parliamentary Forum for Health and Wellbeing in the Eastern Mediterranean region and of Women Political Leaders, a prestigious global platform and network with a mission to empower women in political leadership. Dr. Inaya, the floor is yours.
Thank you very much. I will start by thanking the organizers for inviting me to this webinar. It's my great pleasure and honor to be with you today. Actually, in my position as a parliamentarian, I would like to start from my constituents, from a right-based approach, a citizen-based approach. What do our constituents and our citizens want from the government as far as health is concerned? Of course, they want to see that their health is being promoted not only by receiving medication or health care service whenever they are sick or ill, but to see their health and well-being promoted by the many dimensions of the constituents of health, which is, it was mentioned before, good quality water, good quality food, employment, air, good environment, etc., etc. And they want also their health to be protected against hazards of all kinds, against earthquakes, against floods, against volcanoes, against pandemics like the one we are witnessing now, and against road accidents. And whenever they get sick, they want to be able to go get their diagnosis or get access to a quality clinical service where they get quality doctors making the diagnosis with quality testing. And if they need a hospital bed, it should be accessible to them. And in cases of pandemic, they would like to see that the continued healthcare not disrupted, and they like to see themselves protected. In seeking this medical care, of course, they expect, every citizen expects to have some social protection and financial protection, not to go bankrupt or impoverished because he or she has to go to the doctor or to seek medical help. I would like to draw from the example of Lebanon to discuss the issues of collective action, collective functions, and governance issues. Well, is this happening in Lebanon? I would like to talk very frankly from a parliamentarian point of view about maybe the time before the pandemic and during the pandemic. Well, before the pandemic, I would like to say that we have around 1,800,000 Lebanese citizens without medical coverage. And whenever they get sick, for chronic diseases, they go seek, especially cancers, they go to the ministry. They are covered by the Ministry of Health. Of course, we have, like Dr. Ammar mentioned, we have a network of primary healthcare centers, but it's still suboptimal because the plan that was decided to expand this network was approved maybe last year, and we didn't have the time to do it. And let me tell you one thing, that most of the spending on healthcare in Lebanon used to be done by the public sector within the private sector, which is way stronger than the public sector. And also within the health sector itself, we have a lot of fragmentation, even in the official, in the official public health sector, like the Social Security Fund, the many security agencies, the many funds, there we have fragmentation, we have different pricing. Also the market is very, let me tell you, health service has been dealt with in Lebanon as a commodity, not as a common good, because it was left to the private sector without strong monitoring. And there has been maybe excess of some health facilities, diagnostic facilities with a pricing that is not very well controlled, or maybe not controlled at all. And this led to a lot of duplication, led to a lot of wasting in the budgets, in the financing from the government within the public sector and from the out-of-pocket money of the citizens. So, and also at the level of the financing, there was no alignment between these different covering entities. Why is that so? Because I think most of the focus was done on this operational level from the government without taking very much good care of the overarching stewardship and regulation function that the government has to do over the health sector. And I think it has to do with how the government or the state, as you were mentioning, views its role. I think the vision itself, one of our distinguished spoke about it. I think the vision of this collaborative, this collective contribution of so many sectors to health is not there. And as a consequence, we don't have any collective action that is very well integrated between the different sectors. And this fragmentation happens between sectors, within sectors, and at many levels of the government, between the center and the villages and the periphery of the country. And this is causing also a lot of duplication at the financial level, and a lot of wasting. And I think any transformation in the governance of the healthcare sector, of the health sector in Lebanon, has to take care of the stewardship and the regulation layer, starting from the policy setup. Who will decide that what is the policies that have to be taken into consideration to collaborate together to bring these different actors contributing to health together, and what is the relationship that has to govern them? I think this is not a technical issue, this is highly political issues in a country, and I think in most countries, we have to make this dialogue and we have to agree. A lot of ministries here in Lebanon work as monopolies for the minister, and they refuse to share data that are very important nowadays for making decisions, for the surveillance, for delivery in an efficient and economic way of services. So this dialogue and this landscape of actors has to be done, and we have to come to an agreement on a vision reflected in a policy that needs to do a policy setup. But who is responsible for this? It's the government. The government has to do, and namely, I think the parliament has to play a good role in this, because maybe if we leave it to the executive, a lot of vested interests will be a constraint to this approach. Another level that we have to take care of at the level of the stewardship and regulation is the regulatory oversight over the different actors that have to do with health itself. We have to put the checks and balances. We have to define the roles, to assign them to the different actors, to give them some, regulate their authorities in order to be able to make them, hold them accountable to their forces, to their acts. We need to coordinate, go to the level of coordination between these different actors also. We have to take care of at the regulatory level of the qualifications, of the licensing, of the accreditation. We have to take care of this. And also at the management level, at the crisis management level, there should be created an entity, a body that in disasters, in pandemics, can take over this coordination level and can preemptively put scenario analysis in order to keep the healthcare services continuous during the pandemic. The parliament, I think, has to play a role in ensuring the legislative environment that can take care of this and to draw the architecture of this institutional setup that can make every one of these functions in place. Through the dialogue, through legislation, through pushing and advocating, through building the case for a collective collaboration for health. I think universal health coverage, transformation of the health towards the universal health coverage needs really a transformation in the vision, needs a transformation in the governance at all levels, within sector, between sectors, and between different levels of the environment, but also it needs a transformation in the budgeting setup and in the alignment of the budgeting towards outcomes and towards more transparency and more collaboration. And this is also has to be taken care of by the oversight and by building the case towards this collective vision and collective action for health. Thank you. It's very important to link the SDG 3, the health, to SDG 16, anti-corruption and strong institutions. I think has to be present in all sectors, as well as anti-corruption and governance has to be present in all sectors. And I want to draw the attention also to the role of women leaders in this course, in this transformation. Drawing from the pandemic, Anna, I would like to talk about the women-led states that really performed better than other states. Of course, not because they are women, they performed better. I think they performed better because previously they acted preemptively in putting in place well-governed health care sector and taking into consideration this collective function approach. And I think we should go and look into the details, into the governance and the financing of the healthcare service in these countries. Thank you.
Thank you, Dr. Inaya. This was a great tour de table roundtable around these issues. It's interesting the last point that you make about the role of women leaders. I was in a panel yesterday on women in global health about the same issue, and we reviewed a few decisions that were made related to the COVID-19 response that would have been different if women had been in leadership positions, and that's quite interesting to analyze actually per se. But that's not really, I mean, it is the topic of today, but it's a side topic of today. We have a few questions in the Q&A box that I have tried to sort while you were speaking. Of course, we won't be able to answer all the questions or review all the questions. The organizers will probably tell us that we don't have a lot of time left. But I have selected a few if you want to make some comments. For example, for Dr. Inaya, I think you really laid down something that Dr. Soucat also very frequently presents as the 3 Ds, the DDD, the data, dialogue, decision. You really related to that, and that it's saying that data is a common good. It is something that actually belongs to everyone. And there is a responsibility to share data, to make data publicly available. And Dr. Sameen, Dr. Siddiqi also referred to that transparency and that accountability, linking your presentations. There is a question, however, about the fact that the short-term interests, also the hardware interests. There's a question that says, if we want to look at the data, look at dialogue, look at transparency, look at sharing and participation, we're looking at software. And communities, as well as governments, a lot of the time are interested in hardware. They're interested in seeing hospitals built. They're interested in seeing technology put forward. So how can we overcome that? How can we overcome these short-term expectations of governments as well as communities, let's face it, and really direct their interest and demand toward the software investment and the pathway from data to dialogue and decision making. Dr. Sameen, would you like to start briefly on this aspect?
Yes, I would. And because I will have to make a presentation in another 10-15 minutes. So with your permission, I would be leaving a bit early. And my apologies for that, but I will have to leave. So I think we all know this and we have discussed it. The life of a politician is much less and shorter often than life of a researcher, for instance, you know. And politicians want results in 3 years or 2 years or 4 years, what they have, and that's why they want to invest in areas where they can win back, you know, the parliamentarians or come back to power once again through whatever means they can. And that's why they have these short-term. And I think there's nothing particularly wrong with that because that's the way it is. However, I think we have to work at 2 levels or 3 levels where I think we can make a difference. First is we need to create some demand. And I think today COVID offers that demand so that today everyone realizes the importance of surveillance, the importance of the softer side of public health, both the community, the NGOs, the media. I mean, today in every country, you see 10 articles on COVID. And so this is an opportunity which we should not miss. And I think we should try and see how we can raise public health and the importance of common global health goods on the agenda and sustain it over time. So that's for me clearly one of the big opportunities which I think WHO and Agnes, you lead this work. We are with you, but I think we have to come up with something very, very constructive, which is directed at our policymakers, because COVID will be there. Maybe it's not there next year or maybe less, but I think this opportunity should be used. So that's one. The other part, which I think where I also would like that people, parliamentarians like our Lebanese colleague from Lebanon, I mean, she's such a pleasure to listen to, you know, because if that is the kind of parliamentarians we can start having, and I totally agree with you, Inaya, in my country, the women parliamentarians are far more receptive to these kinds of issues. So if I have to talk to these issues, I think I must bring, and there are plenty, the 20% of the parliament in my country are women, right? Yes. And I think we need to invest more in this because not only will they be able to take this agenda forward, I think they really are much more committed. So I think targeting and looking at women, not targeting, sorry, that's not a good word for women, but looking at women and, convincing, making a convincing case is important. And I think my last point would be that the academia also has to play a role when it comes to this. I think we as academia have not done enough, and that's why governance remains an understudied piece of work. And we as academia need to come and start doing some normative work. And my last comment, and Agnes, you are leading this work in WHO globally. I always say this, we need to learn from the economists. 30 years ago, our thinking on health financing was fairly elementary. I mean, in the times of Al-Ma'ata, the thinking on financing was very limited, basically. But the way the economists have taken the thinking and advanced it over the last 3 decades, today, I think it's pretty much cut out, and we all understand people who are non-economists. I think a similar kind of work needs to be led by WHO on governance, Bring in the political scientists, bring in the right people and social scientists. And I think we should then start some normative work around governance, which over a period of years would then allow us to translate that into tools, do the assessments, convince policymakers, and start sort of, trying to make the kinds of interventions that we need to improve governance. So I think it's a collective responsibility. It's not one institution's responsibility, but if we come together and work together and use this as an opportunity, I think we will be able to make a difference. So I'll stop here. Thank you very much.
Thank you, Dr. Sameen, for this insight. And indeed, the role of academia, I believe, is extremely important. Dr. Maha, would you like to comment on this question of how we make sure that we focus on this software rather than the short-term hardware that people may expect?
Well, thank you very much, Taban, for the discussion, and thank you for bringing out the role of the academia, the role of the parliamentarians, the women parliamentarians, and the women leaders. It's really very it gives a hint that there are directions that could be made use of in the coming future. So I would just grasp the opportunity here to mention that in order to make this change between the soft and the hardware, and how people are thinking, how politicians are intervening, and how the immediate successes or the low-hanging fruits are really impeding any longer-term, maybe sustainable changes in systems and even in systems thinking, I would like to build here on the number of initiatives that have been undertaken in the region. So there are a number of champions and experts who have emerged, and many of the stakeholders and different entities, they are capable now of moving the way forward towards a more to a proper system governance and data collection part, data transparency, data sharing, and as well the data generating the data itself. It's not only about data which is available and not used, it is the kind and type of data that needs to be generated to be as well shared and to make sense of things that are happening. So we need to build on our structures that are there. We need to build on the past experience to move forward in order to facilitate this hard software, and how to change, I would say, and how we need to change to have the bigger picture in mind. And this requires a strategic mindset for everyone, for those working with the community, those with the politicians, those with the academia, those on the global and on the state level. We need to have this, the bigger picture in mind. What is it that we really want? What are our entry points? What are our strengths and the gaps that are there? So it requires a strategic mindset that focuses on the overall health system, given the three pillars of the policy, the providers, and the community. And here I would add the community and the different stakeholders in the community there. And I would put here the academic departments or the academicians, the researchers within the community component, because they are part of the community that really relates to the policy level and to the provision level. So it's the mindset, the strategic thinking, and how we rethink of restructuring what is there in order to support the governance, the leadership, the commitment, the transparency, and all of the other aspects that are needed to support essential public health function services as a common good as well. So changing of the mindset, and this needs creating the needs and the demands. But we have to start to continue what has begun and not to start anew. This is a continuous process, and it really is continuous, and it needs to be as flexible and adaptable to change the overall thinking of the situation. Thank you very much.
Thank you, Dr. Maha. I will take another important question in the chat box, in the Q&A box, which also was reflected in your respective presentations. I would like to direct that to Dr. Ammar and Dr. Ezzeddine after that. COVID-19 is an opportunity. You have all mentioned that, and it is coming up in our question and answer box as well, quite prominently. So it's an opportunity because governments start seeing public health. We talk about public health every day. It has penetrated through media in every single household, how it is important to wash your hand, which is brings us to some of the common goods that we are talking about, which is access to water to be able to maintain hygiene, for example. It's just one example. So it has really sort of been very powerful in penetrating every single layer of our society. That is why it is an opportunity. But how to transform this opportunity? One of the questions we have in our Q&A box is, for example, how to avoid another type of capture. There was a capture towards curative care and hospital care. We just discussed about it. So how do we make sure that we of course prevent outbreaks in the future, but there is not a emergency outbreak capture of this window of opportunity? That, for example, we also address some issues related to climate change, to tobacco legislation, to food systems, for example, etc., and that these also become things that are high on the agenda to be able to prevent deterioration of population health rather than having to propose cures. So how do we make sure that, how do we prioritize basically within this window of opportunity, how we are going to invest our newfound interest in public health? Dr. Ammar?
Yes, thank you. Well, I think the opportunity now that people are aware of the importance of public health issues, it creates a climate where people are more receptive maybe to invest more in public health, in the public sector per se. And as I explained, that some collaboration mechanisms that proved to be efficient in such a situation, because in a country like Lebanon, with the really a very strong private sector, and with the tremendous financial constraints in the public sector, we cannot but rely on the non-governmental sector, whether it is NGOs and even private for-profit. So there are mechanisms that showed to be efficient in such a situation. The problem is, or the question is, how to institutionalize this to make it more sustainable for the future, not to rebuild everything in facing emergencies. So I would say that we should consider both strengthening the public sector, and people are receptive because public hospitals were for a long time neglected, and the main public hospital, which is the University Hospital of Beirut, Hariri Hospital, showed to be really very efficient and acted promptly in fighting COVID-19 and treating patients. So people are more sensitive now to invest more in the public sector, but also to institutionalize the relation of the public sector, of the government, with non-governmental sectors, whether NGOs or even private for-profits. And the orders, professional orders, have played an important role also, and they should be associated in the decision-making process to have this kind of participatory leadership to face, major problems as the COVID-19 pandemic.
Sorry, I was muted. Thank you, Dr. Ammar. Dr. Ezzeddine, would you like to comment on this topic further?
Thank you very much. Yes, as you mentioned, of course, the COVID-19 pandemic is a resetter, is a change in paradigm opportunity, and it offers opportunities, not only threats, provided that we have the right vision, the right insights into the problems that have caused the suboptimal and sometimes the collapse of many healthcare systems in the region. Tobacco is an example of the need for the collective action in order to go to health. Of course, smoking and tobacco use is a health issue. However, the fiscal mechanisms to control or to curb the tobacco usage is in the Ministry of Finance. And here comes the importance of alignment of the budgeting procedures with the overall policies that have to be taken care by a policy setup and by an institutional setup that can guarantee the collaboration and the outcome of this health problem. The same applies, for example, for sugar beverages, for alcohol consumption, and here is the Ministry of Finance with the overall vision of health. This also is an example of the overall, the overarching layer, the software layer that you were mentioned. The software is very important. And I think COVID-19 has proved and given the case for this software to be in place because of so many gaps and deficiencies that proved to be present in our healthcare system that mainly focused previously on the hardware, if you want, healthcare system. We're building hospitals, and that gives short-term rewards for politicians. And as I mentioned, this is a political, very big political challenge in our countries, where there is lack of openness, lack of data collection and sharing, and lack also of, if we want to build up or predict new pandemics that can emerge in the future, we need this sharing of data, collection of data between the different actors, between the academicians and the different stakeholders in order to analyze this data and make usable knowledge out of this data, able to predict future pandemics, future health crises, and in order to put anticipatory preventive measures, or else we would always crash and collapse in front of every crisis that we might face in the near future or in the long-term future. Thank you.
Thank you, Dr. Ezzeddine. I would like to take a last set of questions from the Q&A box, and I'm really sorry that we cannot answer all the questions that are coming in, but we will have to address another set. I think I've grouped them around the issue of accountability towards whom. How can we manage, who is going to put accountability on governments, who is going to make governments accountable. There are a number of issues there. We hear that, there's a question in the chat box saying which international institutions can hold governments accountable for delivering on these common goods for health or public health functions and for good governance. On the other hand, is this the role of international organization? Isn't it back to the public, to the population, that the population is the principal and is basically there to hold governments accountable? And therefore, what is the role of local health system, local policy making, and how can this be used as an avenue for basically making governments deliver on what they need to deliver? And I would like to link that and have your views to something that Dr. Abou Taleb put in her presentation, which is the historical determinants of what we are seeing right now, and especially a colonial history, whereby some of the institutions at local level or at national level are still depending on some influences from not necessarily the community, or it's not necessarily the community that's the principal or holding accountable, but some other instances that are embedded in these historical pathways. So I'll be happy to hear your views. This is a complex question. It's a complex governance question, but we're finishing with this complex governance question that I personally believe it cannot be ignored in the way we build our future. Dr. Maha, would you like to start?
Yes, thank you very much. I like to just respond on different levels, particularly for the COVID-19. It is well proven that no one is safe until everyone is safe. So who is accountable to who? We are all accountable to everyone. So how to hold countries accountable. Definitely, there should be some sort of a way not to hold them accountable, but a way to raise the responsibility, for solidarity, to just have like this common strategy that has to, or common things that have to be applied on the global level in order to support the protection and saving the lives of everyone on the globe, I mean. So there are different sets of responsibilities and accountability. But when we come to on the regional or country level, definitely we need to visit and reassess the governance structures, the independent structures that are available on the country level, and how they are functioning and how they are put into their account, to perform their accountability job, or the job description of whatever, like the parliamentarians, like the health councils, like, so there are structures that could be, that could make the response, or could respond to whatever is happening on the ground, and holding people accountable in a way that supports the overall response that we are talking about. The issue of the climate change and how to prioritize, and how we know that we are saying we need collective actions. And when we're talking collective actions, and given the complexity of the situation, we have to realize that policies or decisions that are taken outside the health sector or the health system are affecting the response and affecting the outcomes of the health sector and the system itself. So as we're talking collective actions, and as was always mentioned by the WHO, it's a whole government approach. And definitely it is a whole government approach, while all of the different sectors, all of the different with intersectoral and multi-sectoral coordination to support the response. And here we're talking a COVID and non-COVID response. So we're talking climate change, we're talking environmental, we're talking the financial part, we're talking, so this is a collective action that has to involve the whole of the government as well. As we're talking about the independence or the transparency system present in countries, we have to revisit and reassess and to find out exactly the gaps for the real performance of the governance structures, and how they are manipulated in a way, or how they are suppressed in a way, in order to suppressed or not suppressed, not necessarily suppressed, how they are functioning in order to perform their accountability and take it forward for reforms. So when I'm talking accountability, I'm talking about inefficiencies, I'm talking about reform, I'm talking about suggesting other strategies. I mean, it's like a collective action for the support of the response now and into the future. So accountability is part of the overall way the government is undertaking its course, and the overall the general presence of the structures, governance structures, and how they are performing on the country level. Thank you very much.
Thank you. Thank you, Dr. Maha. Dr. Inaya, would you like to comment on this topic?
Who is going to be accountable to whom? I think this can governed by a certain institutional setup that can be initiated by Parliament, starts by legislations, and then that will give the directions or the framework for the institutional setup of the responsibility of every actor in this function. And what is the responsibility? What is the power given for them to fulfill the responsibility, and the accountability structure? And this should be, of course, later on measured by some metrics that have to be put in place by the executive layer. But I think institutional setups and the accountability structures governed by some legislations can take care of this. Of course, besides this, we have the community also has to play a role, because after all, citizens are the source of all the authorities. Democratic, we have to inform, raise awareness against for this. And as we strengthen the democratic spirit by making knowledge, by making data accessible to people, this will improve the openness, improve also the accountability of every person in power towards the people. So this is very important, and to make this shift from building hospitals, getting the reward from building hospitals that maybe we need them, maybe we don't need them, to policies and to regulations and to oversight and to accountability. I think everything we went through in this region, and let me talk about Lebanon, proves the point that accountability and governance and anti-corruption and transparency and reform has to be at the basics of every authority given to to the political class. So as much as we encourage this through openness and through access to information, we will be improving accountability in the health sector.
Maryam, may I add something, please?
Sure, please.
Okay, so just reflecting again on what Dr. Ezzeddine and all the presentations. So I think that we need to have the necessary legal or regulatory frameworks. They have to be in place, and to establish those institutional structures to enable the governments to fulfill the responsibilities. And they have to be in place and they have to be supported. And this requires the political will and the political constitution and institutional setup that really supports the presence of those institutional structures. So it will include the stewardship, the regulation, the capacity for the intersector. So all of this, they have to be put in place, not only for the COVID, but for the running and for the sustainability of any system that needs to be institutionalized, and in order to support its sustainability as well. Thank you very much.
Thank you. Dr. Walid Ammar, to finish this round.
Yes, thank you. Well, accountability depends on the governance structure. And if you have a framework of collaborative governance, all parties should be accountable to each other. At the end of the day, everybody is accountable to the population. And political accountability is very important. And I would like to go back to what Agnes put in her presentation about identity. You know, accountability, political accountability in our country, for example, is perverted by confessional consideration, because there is a confessional identity that is more important sometimes than the national identity. And this is a very important issue. And the other side of the accountability, when we talk about accountability, we talk about transparency. And this is related to the first question about data. Well, availability of data or sharing data as a common good is not always, the problem is not always the lack of transparency. Sometimes there is a problem of institutional capability. And this is where comes the collaboration between the academia and the public institutions, because to generate data, to analyze data, you need people who know how to do it. And we have, I would like to share our experience in Lebanon. We have a tripartite agreement between WHO, St. Joseph University, and the Ministry of Health. We have created the Mediterranean Academy for Learning Health System. So the purpose is to put together academicians with people working with policymakers to work on generating data and sharing data and using data. And this would enhance tremendously the accountability of all partners, particularly the public sector.
Thank you very much, Dr. Ammar. We are reaching the end of this webinar. It has been fascinating, really interesting to hear all of you speak of your personal experiences, your country experiences, reflecting on this proposal of the Common Goods for Health and Essential Public Health Functions proposed by WHO. It was also interesting to see that we rounded up this discussion saying how data is important and how this can actually be the driver for change, to be able to access information, to be able to share information, to use information for decision making it has been a critical component of how we are going to seize this window of opportunity. And I would say that the health sector could be the leader in this area, could be could be a role model for other sectors, sharing the data. Another aspect that's extremely important as well in terms of the whole of a government approach is to ensure that at least some common basic health indicators are always embedded in assessment of all public policies, and that data would be an incentive for a lot of public policies to be more aware of the impact of the policy implementation on health of the population, whether it's it's a health policy or not. So this is, I would say, a summary of your last round of intervention. And to be able to close this very interesting webinar, I would like to call Dr. Soucat and Dr. Abou Taleb for a short closing remark. We're starting with Agnes.
Thank you very much, and thank you to all. I learned so much today. From all the panelists, and it really so I want to give 3 messages to conclude. I think the first one, I really want to tell Dr. Sameen, although he has left, but that we hear his call. That WHO has actually started working on the normative side of governance, the way we have done on financing over the past decades. And as you've seen what I presented today with the triangle, we actually now have the WHO framework on health system governance that was recently published, which relies on this governance, on this triangle. And we are developing on this basis analytical tool that systematically does a diagnostic of the governance of the health system, not only a diagnostic of what is happening in the 3 main stakeholders, policymakers, providers, and both of them answering to people, but also within each of the stakeholders. For example, particularly in the case of common goods, looking at how people relate to each other. What are the dynamics in society that lead to collective action? What are the fractures in society, and how are public resources allocated to people? So really first answering that call. Second, very much agreeing with what everybody has said, that COVID-19 has really brought about the salience of the problem. I think now everybody agrees that this sort of hidden, this big problem, but that was hidden under the radar, is now out. And everybody said, you said, there is a call now. People are asking for more action from government to address those fundamental issues. So we have this window of opportunity, and I very much agree that actually this window of opportunity could disappear. We could get the vaccine and in 2 years have gone over this crisis, and then just relax and wait and basically being hit by the next crisis. I don't think it's going to happen that way, because what we see, for example, from South Korea, and when we listen carefully to the Koreans about how they successfully respond to the pandemic, they say that they learned a lot from the previous ones. Right? It's because they've been hit by the first SARS, by MERS, that they now have strengthened their capacity in public health. And the third is really very much aligned with the message on essential health, public health function. There is no intention at all in the common goods agenda to create any confusion, right? For us, the common goods is just a financing economic concept that serves the essential public health functions, right? So the essential public health functions is what needs to be funded because they are common goods. And I'll really say that what I heard today is really encouraging, because now I think we understand, if we refer to the triangle, that the essence of collective action is people, it's citizens, is the people, it's people. We need to develop institutionalized mechanism. It was said by all of the panelists. We need to build institutions that bring people into the dialogue, societal dialogue, national health assemblies, États généraux de la santé in the French-speaking countries, and more probably than anywhere else in this region, in the Middle East and Mediterranean region, because it has a long history of change in nation building and a complex history, as we know, and a history that has led to many conflicts. And that's why the building of institutions that bring people together is not an option, but certainly it's not an option when it comes to common goods. Thank you very much, and thank you for all your great insight from the countries. That was really amazing. Thanks.
Thank you very much, Agnes. Thank you for taking the time for being with us in your busy schedule. I will leave the floor for Hala, Dr. Abou Taleb, to close the webinar. Thank you.
Thank you very much, Maryam, and yes, and all colleagues and panelists. Thank you very much for, I will not take much of your time. We agreed that we know it's not new. The COVID-19, actually, it was an eye-opener. It emphasized a lot of what we already knew needs to be done. The good thing that we need to use it as a catalyst for change. The change that they've been calling for a lot of years, for decades. Now is the time to seize this opportunity and avoid allowing it to slip from our hands. Politicians now need to be on top of things. They need to work closely with health experts, academia, legislators, and civil society, private sector, and so the list is long. So WHO is working, as Agnes was mentioning, to develop the normative work at the regional level. We're collaborating with all regions and HQ to make sure that we have the regional context and country lenses being applied, because this has to be country-driven. Governance is political, as we all agree today. Institutional strengthening, regulations, participation, bringing the voice of the people, and making sure that our institutional setups are fit for purpose and supported by strategic information, and the governance of data management is very important to make sure the regulations make it transparent and to hold everyone accountable, not only the executive arm. If we call for collective action to advance universal health coverage and health security, this means that this collective action has to be translated into collective accountability. Thank you.
Thank you very much, Dr. Abou Taleb. Thank you to all the panelists and the speakers. Thank you to all the participants. So thank you, all of you, for your powerful messages, for your clear and transparent messages.